All right. Am I good to go ahead and share screen?
Yes.
Okay. All right. So, everyone see the screen? Are we good?
Yes.
Okay. All right. So I'm Taylor, for any of the first years who haven't met me yet. And I'd like to thank Dr. Kirshner for being my mentor of this case, and the very original title of complicated cataract. Should be an interesting case surgically for everyone to learn from. And these are the disclosure slides and the accreditation slides that are at the front of all of them, and then a reminder to evaluate at the end. Okay, so the initial presentation of the patient. It's a 54-year-old male who was initially referred by an outside ophthalmologist for retinal detachment with an inferior horseshoe tear and superior dialysis, left eye for about a year. Very limited history from the patient's perspective. No trauma, though at least he denied any trauma. Underwent a pars plana vitrectomy, membrane peel, endolaser, and silicone oil in the left eye about 6 months ago with LSU Retina. So he came to us with a retinal detachment that was there for about a year, he thought. And then I'm now seeing him 6 months after the retinal detachment repair by Retina in Baton Rouge. So on the initial exam, the patient's visual acuity was 2500 in that eye. Motility was intact. Pressures were fine. The anterior segment exam, the pertinent things to look at. He had posterior synechia from 10 to 2 o'clock. A silicone oil bubble taking up about 70% of the anterior chamber. 1+ nuclear sclerotic cataract and 2+ posterior subcapsular cataract. And the vitreous was silicone oil 95% fill. And then as far as the fundus exam, there's a blurry view because of the cataract there and the silicone oil. But the disc appeared pink and sharp with a normal cup to disc ratio. The macula was flat. Attenuation of the vessels, and the periphery looked attached, and there was laser 360 degrees as well. So as far as assessment and plan with a patient that has all of these things going on, so he does have the nuclear sclerotic cataract and posterior subcapsular cataract in the left eye with silicone oil in place. It was visually significant and would help improve the view to the retina to have it removed. The retina was flat and attached, and you have this large silicone oil bubble in the anterior chamber and posterior synechia from 10 to 2 o'clock, so 4 o'clock hours of synechia. No history of Flomax, no Goutte seen, which are important things to evaluate before you do cataract surgery. And so we'll need Stripan blue and synechiolysis superiorly there, with hooks and or a Malyugin ring during surgery, and we'll kind of talk about that as well in the future. So after our discussion with the patients, including unknown visual prognosis because he had a previous total RD with the macula off, and there's silicone oil in the AC, which makes the A scan unreliable because when the velocities of the different substances, when you go from front to back, usually you have just the aqueous followed by the lens, and then the silicone oil in a case of a patient with silicone oil vitreous. In this case, there is silicone oil in the anterior chamber, so you have aqueous just inside the corneal endothelium, and then silicone oil, and then more aqueous in the posterior chamber, followed by lens, and then silicone oil. So it makes the readings for the A scan unreliable and overestimates the length of the axial length, and we'll kind of get into that a little bit in a second too. So unable to get optical biometry, so we used axial length measurements obtained from the contralateral eye. So just to be clear, and these are the IOL calculations, the left eye is the eye we're operating on, the right eye is the fellow eye. So we use the Ks from the left eye and the axial length from the right eye to create a plan for what kind of lens to insert in this patient. So we ended up choosing the 23.5 diopter lens with a target of minus 0.39. and we'll get into a discussion about the IOL calculations in a minute too. So like I said, this is the plan, the 23.5 lens, trying to put it in the bag. Okay, so kind of an open discussion to mainly, any of the residents or any of the third years that are there, what things to think about for this case. Anyone have any thoughts or, plans as far as the order of sequences, the order of the events that you would do when you operate, or other things to worry about?
Yeah, Taylor, I guess my first thing was where was the silicone oil bubble sitting in the AC? I mean, was it obstructing your view completely of the capsule?
Yeah, so great question. It was taken up about like 3/4, so 75% of the AC. So yes, it was obstructing pretty much the whole view to the capsule there.
So I guess my thought would be, you got to think about how to remove that. And then you have to also consider the order of what you're going to do as far as your trypan. And if you're going to use that prior to the Malugan and prior to your visco, and having a plan before you get into the eye.
Yeah, I mean, that's exactly what that's exactly right. That's what you want to think about. And so especially, with trypan, you have to stay in the capsule before you put the viscode in. So, with a sneak pupil as well, that's another thing to think about. You might not be able to stay in the entire capsule that you need and get a view to where you want to do the rexus with a sneak pupil. So, trying to plan out what you want to do optimally. We'll talk about the steps for that, but yeah, you're exactly right. So, and you have to stay in the capsule before you inject the viscoat, because the viscoat will stain with the trypan blue itself. So then you'd have to start over. All right, so surgical approach. So those things, kind of like what Wade got into and what we've been talking about, several things to think about, including lens calculations in a patient. They're important to think about in patients who have silicone oil in the vitreous cavity, and also in patients who have silicone oil in the anterior chamber as well. And then the trypan blue in the order in which you would inject it, how to do a synechialysis and when to do that, Malugan ring versus iris hooks. And we kind of talked about the silicone oil a second ago, and then especially coming up with a plan pre-op in order to tackle this in the correct order and be as efficient and safe as possible. So first thing first, starting with the lens calculation, you got to think, is the silicone oil remaining in the eye or is it being removed? So if it's remaining, the most commonly used practice is to add +3 to +3.5 diopters to the lens selection. And this is after changing the lens to a silicone oil, or changing the biometry to a silicone oil eye. And if it's going to be removed, then the standard formulas can be used to achieve the desired calculation. So this is an eye that just has silicone oil in the vitreous. This is kind of the approach that you would take. So how you do that, you use IOL Master, change the settings under axial length to silicone field eye or silicone field eye aphakic, depending on the situation. And the whole reason to do this is you don't want hyperopic surprise from not changing the settings, because silicone oil overestimates the axial length, which will lead to a hyperopic surprise if you put that recommended lens in there without adjusting for this. So all that is to say, in the case of silicone oil in the anterior chamber, this changes the IOL Master measurements as well as a manual A-scan. And that's ultimately why we decided to use the fellow eye for the axial length, is because like I was getting into earlier, the changes between, going from aqueous to silicone oil to aqueous in the anterior chamber, followed by lens and silicone oil again, it just throws off the readings. Okay, so getting to the trypan blue part of the surgery. So when would you inject? So formation of the paracentesis followed by injection of trypan blue. In our case, there's no need for lidocaine as the patient was under general anesthesia. So you stay in the capsule of the trypan, including just under the pupillary margin, very carefully, especially when you have the synechiae there. In our case, put the injector just under the pupillary margin to inject so you can get more of the area around there, because you want to do a 5 millimeter rexus, or if you're leaving silicone on the eye, a little bit less than 5 millimeters. But when the pupil sneak down, you can't quite get that kind of a view, so you need it to be bigger. So after injecting just under the pupillary margin, and the reason emphasize carefully is so that you don't tear the anterior capsule when you're doing this and pull those synechiae too hard. Then burp the silicone oil bubble out, like Wade was saying. You need to get that silicone oil out. There's different ways to get it out. We'll talk about that in a bit too. But this big oil bubble was pretty easy to come out just by burping. And then injecting BSS to wash out the trypan blue before you inject the viscoelastic, because the viscoelastic will also stain with trypan blue. And then, for the first years, this is a rexus being formed, and this is trypan blue staining the anterior capsule. So you can see they're about 2/3 of the way complete with the rexus. And yeah, that's kind of what the goal is there with trypan blue. All right, so the next problem is the synechiolisis. So how to perform, what instruments? So you can use the viscoelastic cannula to remove the synechiae. In our case, that's what I did at first. So I started out at about 10 o'clock, removed in a sweeping fashion over toward 12 o'clock. And then there was an area that was not being removed easily with the viscoelastic. So started over at 2 o'clock and did the same motion back toward 12. And that area still remained. So we went ahead and did the biplanar temporal main wound with a keratome blade, and then inserted a cyclodialysis spatula to remove that final strand. So a cyclodialysis spatula is really good for these, for removing synechiae. And if you're having trouble with the viscoelastic cannula, then you can use the cyclodialysis spatula. And then another step that wasn't in our case, but you can consider removal of the fibrotic pupillary membrane in circumferential pattern, not radially. And this is because that fibrotic membrane can mechanically prevent mydriasis and adequate exposure of the anterior capsule to perform the rexus. So I was going to try to show a quick. How do I get this out? Just go away. From Cataract Coach, which is a great resource for any people who haven't heard of it.
Taylor, while you're pulling this up, this is Sprague Eustace. The vitrectomy scissors are very useful for cutting synechiae. I find if kids get this really bound down situations, and yanking on it isn't good, because you're better to cut it. The vitrectomy scissors are very useful and easy to use.
Okay, thank you for adding that. And are you guys able to see this video now that's playing?
No.
No? Okay, maybe this just won't work. I'm not sure.
You may have to share the actual video, because I think.
Oh, a new share? Okay.
Right now, yeah. You either have to share your whole desktop or the video. There we go. Now we can see it.
Okay, can you see it, the whole thing?
Yep.
Okay. So you can see just how he pulled. Sometimes I've seen some other videos of these where it's more extensive, but you can see how he's pulling them circumferentially and not radially, and that's so you don't tear the anterior capsule and have it extend out. But pulling it circumferentially is kind of the point that I was trying to make here, and that he's illustrating. Okay. So if I just click this, then it'll share my whole desktop, right? Okay. All right, so next, and then, so this is just illustration of the posterior synechiae and a cyclodialysis spatula, just what it looks like, the instrument that I was talking about earlier. Okay, so the next part of the surgery was the Malyugin ring. So now that we've got the synechiae broken up, we have good mydriasis, and we inject a little more viscoelastic and ensure that the AC is deep before injecting this Malyugin ring. And a great tip that Dr. Kirshner taught me about was to inject under the nasal aspect of the pupillary margin with a little bit of viscoat before you inject the Malyugin ring, so that way it's kind of elevated and right there, so you can easily engage it nasally with the Malyugin ring. So engage the nasal aspect of the iris first, then attempt to engage either the superior or inferior next, whichever one is easier to come by, and hopefully you can get all three before using another instrument to place the temporal one. So you can use a Connor wand, Malyugin ring manipulator, or Lester hook. And there's several different ways of doing that to engage the temporal iris finally, or to manipulate the Malyugin ring if you need to. And the reason that I say AC deep here is because a lot of surgeons prefer if the AC is shallow, which is important, especially in a silicone oil case, to use iris hooks instead. So since the AC was deep here, we elected to go ahead with the Malyugin ring. And so this is a Malyugin ring for any of the first years who haven't seen one before. And these are iris hooks. So a Malyugin ring on this side, and this kind of illustrates what I was talking about. So injecting a little bit of visco underneath the iris nasally here, and then engaging with the two rings, followed by the superior and inferior ones as you're kind of removing temporally. And the iris hooks, these are different. You have to go in and create little paracenteses everywhere that you want the iris hooks placed. And both of them have their benefits and their drawbacks, and we'll talk about that in a second. Actually, we'll talk about that now. So this is a study done in 2019. It's iris hooks versus a pupil expansion ring, operating times, complications, and visual acuity outcomes in small pupil cases. So the objective was to compare iris hooks and pupil expansion rings in eyes with a small pupil. This is a retrospective case series in London, United Kingdom. So they had patients who had primary phaco from January 1st, 2012 to December 30th, 2016. They excluded surgeons with less than 50 cataracts. And these are the results. Out of almost 10,000 cases, 425 had a small pupil, and 314 of them required a pupil expansion ring, and 95 with iris hooks. And so what they found were that iris hooks were associated with an additional operating time of 14 minutes for consultants and 24 minutes for residents, versus the pupil expansion rings associated with an operating time of 4 more minutes and 6 minutes for the residents. Neither was associated with more intraoperative complications, but the pupil expansion ring was associated with a higher postoperative anterior uveitis, 7% versus 1%, and corneal edema rates, 7% versus 2% for the iris hooks. So, I mean, basically it boils down to it takes longer to do the iris hooks, but there could be, benefit in certain situations in terms of the postoperative outcome. Visual acuity, and they followed these patients out for a year afterwards, and visual acuity was identical between the two groups. There was no increase in glaucoma afterwards. So everything else was pretty much the same other than postoperative anterior uveitis, which was treated, and corneal edema. I didn't see anything about anybody requiring a DSEC. They didn't talk about things like that. Surgical approaches. So back to the surgery. So now we've got the Malyugin ring in, and these are kind of just painting with broad strokes for issues that silicone oil can cause during cataract surgery. So it makes surgery more challenging. The oil's buoyancy increases the posterior pressure. So you have to be very mindful of removing the instruments, especially the phaco tip and the IA, to avoid collapsing the anterior chamber. This wasn't the case in our patient. There wasn't any anterior chamber collapse. But a lot of experts recommend that you could inject viscoelastic through the paracentesis every time prior to removal of the instruments if you are having narrowing and collapse of the anterior chamber. Okay, so now to the capsular rhexis. So after the adequate staining, synechiolisis, exposure gained by the Malyugin ring, use the system to create a nick in the anterior chamber, followed by, in my case, a counterclockwise rhexis, and went probably 5 clock hours until I got to where the remnants of the synechiae were still on the anterior capsule. Once I got to those remnants, the rhexis had a tendency to kind of jerk towards those remnants if you tried to go around them. So we stopped there, went back, reinserted the cystotome, and placed a nick tangentially to the original nick to allow clockwise rhexis. And then once again, once I got up to about 10 o'clock, the remnants of the synechiae on the anterior chamber or the anterior capsule prevented passage once again. So we molded over, talked about a few different ideas, and then ultimately we decided to use Van Ness scissors to complete the rhexis from about 1 o'clock to 10 o'clock, so 3 clock hours superiorly. So we're able to remove the superior and complete the superior edge of the rhexis with the Van Ness scissors. And then after the cataract removal with Divide and Conquer, injected the Helon, IOL was inserted into the capsular bag, and the Malyugin ring removed. The Malyugin injector allows pretty easy removal. So when you depress the injector, you can see what it looks like here. And when you depress the injector and this goes this direction, it actually elevates up. So you can kind of catch it with that hook on the end. So disinsert the temporal ring first, then engage and pull out of the main wound, and the others will follow suit. And if you I'll skip to this slide real quick. And some of the seniors may remember Dr. Bolton, a case that happened a couple years ago where the Malyugin ring got stuck on the iris, and no matter what was attempted, it wouldn't come off. And eventually you can use scissors to cut the Malyugin ring in pieces. I mean, this is a really rare complication, but it's something to think about. So if it becomes stuck and not displaced, you consider cutting into pieces and removing each separately. And then, so following the removal of the Malyugin ring, silicone bubble once again moved around the zonules and into the AC. So use the IA tip to remove the silicone oil bubble and the Helon simultaneously. Finally, there is good centration of the lens noted, and a 10-0 nylon suture is placed in the main wound to allow placement of the vitrectomy ports. And this is just kind of what you're going for with a corneal suture, so 90% depth. Not all the way full thickness, but 90% depth, and then equal on each side, just like pretty much how you always suture. The patient came back post-op day 1, and his vision was count fingers at 5 feet. There was a lot of corneal edema. Pressure was fine. IOL was centered. Retina was flat. Started him on the drops, and we were going to have him return in 1 week, but he has not returned to clinic since, and we've been calling him trying to figure out what's going on, but he isn't answering. So this is kind of where it is now, and we're waiting on him to come back to clinic. So references, several references, especially the cataract coach on YouTube and his own website. I mean, it's invaluable for residents. So if anyone hasn't heard of it, it's great to look at before operating. So in summation, it's just an excellent learning case, and I was glad to have Dr. Kirshner there to guide me through all of this and talk about all these things before we got into surgery. So I think the bottom line is to come up with a good plan and to kind of know what you could be up against before you start the surgery, so that hopefully it can have a good outcome. Any questions?
Taylor, this is Dr. Barron. Did you get an IOL master set on the silicone setting? And just
Yes,
see how much longer was it than the other eye, just for curiosity?
I am not sure of what the axial length read as with I'll have to go back and look, because went in and manually adjusted this axial length here, was entered just, but from the fellow eye. So I'm not sure how much it affected those measurements.
Yeah, I'm just wondering how significant it was that the anterior chamber was filled with silicone. I mean, I would expect it to read a little bit longer, but how much, I don't know if it would be significant.
I'll have to go back and look, because that's an excellent question.
Taylor, this is Dr. Bernal. I just wanted to say that when the posterior synechia are so bad, there's nothing wrong with doing the synechulitis before you do any trypan blue. So when they're pretty bad, I just do the synechulitis first, and then it just adds some more time, and then you just do INA to remove. I always use like a Provisc or a Heal on something that comes out easily, and then put the iris hooks, and then do the trypan blue to stay in the capsule.
Okay. Do you determine that based on like how many clock hours there are, or when you say like when when they're bad?
Yeah, I mean, many of my uveitis patients have it really bad. I mean, like a couple weeks ago, we did one that had like a literally less than 2 millimeter pupil. So they're really dense. So, but even in cases where they're like, I don't know, like 4 millimeters, or like usually just like 360 or so. But if you feel like you're not going to get a good staining and it's a dense cataract, there's nothing wrong with just adding a few minutes to your surgery and having to change the tip from the IA to the phaco.
Okay. Thank you.
Hey,
Taylor, Julie here. Just wondering why y'all
sorry,
didn't
go ahead.
oil first posteriorly, because oftentimes in those cases, the oil can continue to migrate around if there's small breaks in the zonules peripherally, and that can be a pain. In the old days, I'm not that old, but the docs hated operating with oil in the posterior segment, and maybe the new phaco machines allow for much more control, but we always tend to remove oil primarily.
That's a good question. I think it was probably because with a resident operating in case that retina needed to come in afterwards and do a scleral sutured IOL or something like that. I think that was the reason why we went first instead of retina.
Yeah, actually, we usually do it that way for all the patients, Anthony. So I feel like, when you have a bad cataract and you can't see to the posterior vitrectomy, I feel like it's safer to take the cataract out and then remove the oil. So this was a combined case where they did, both things in the same surgery. So it was cataract extraction, silicone oil removal, and we tend to do cataract extraction first, and then we remove the oil, just so we can have better visualization when we're removing the oil. And then Taylor, I guess my other comments were, you can always, if you're not sure if the oil is going to come out or if you're going to have to put oil back in, you can always use a convex plano lens. So basically the thing that's going to give you the refractive error is the oil against the back of the lens. And since most of the IOLs have a little bit of a curvature, the posterior curvature of the lens, that's what's going to give you the refractive error. But if you choose a lens that has a flat posterior surface, you won't have a refractive error with or without the oil. So if you're thinking of a patient that has multiple retinal detachments, or that you're going to have to take the oil in and out, their Alcon has a PMMA lens that's convex plano. I think it's the MC60 CM. You can always choose that one. It's PMMA, so you can't fold it. You would have to make a bigger incision, but those are pretty good when you have patients where oil is coming in and out. And then the second thing is, usually when we do these combined cases, I usually have the residents use iris hooks instead of Malugin rings, because when I do my vitrectomy, I also want a good view. So basically, you finish your cataract, you put your suture in, the iris hooks stay in there so I can see good while I'm doing my vitrectomy, and then I just have to pull them out. The Malugin ring, you can't really do that. Once you're done and you're closing your incision, you have to take it out before you do that. So for most of these combined cases, I prefer to use iris hooks, because you can just kind of pull them out at the end of the case after the vitrectomy. And the third comment is, whenever you're doing cases with post-vitrectomized eyes, even if it's silicone oil, the tendency is to try and bring the bottle up so everything kind of remains down there, but actually the posterior capsule tends to fluctuate a lot, so it's actually better to have the bottle height a little lower so you don't have that much fluctuation.
Dr. Reynoso, did they still make that convex plano? The last time I tried to find one, I couldn't find one, but that's been a while ago.
Yes, yes, sir. I think Alcon still makes it, but to tell the truth, it's been a while since I've had to order one of these. So.
Yeah, the last time I tried, I don't know if Dr. Fitzmaurice, I don't know if you know if they still make it. The last time I tried to find one, they were off the market.
I haven't tried to find one, honestly.
So if you have a patient that's had multiple vitrectomies, would you want to talk to retina beforehand to determine if you need to put in a convex plano lens? Like, is that what you would recommend, to try to talk to them and like,
Yeah, I
as a
guess
team
it's,
figure it
it's
out?
more if there's a worry that you're gonna take the oil out and that retina is gonna become detached again, then you probably want to go with a convex plano, because again, most of the time if it wasn't a complicated surgery and the retina's flat and everything looks good, it's fine to just aim for a lens where you won't have the silicone oil. But if you're not sure, if it was a complicated surgery or there's PVR, hands are going to take the oil out, it's going to redetach, they're going to have to put it back in, then it may be better to go with one of these convex plano lenses.
Okay, thank you. All right, well, thank you guys. I guess I'll stop share now.
Sure, thanks, Taylor. And who's presenting next? Josh, do you know who's presenting next?
Presenting next. Hey, it's Zach Davis.
Okay, go for it.
And let's see, screen share. Okay, can you guys see my screen?
Yep.
Okay. Okay, are we in the slideshow?
Yes.
Okay, cool. Okay, so this is my grand rounds. This is my Rebus puzzle. My name is Zach Davis. I'm a second year, and I want to say thank you to Dr. Walia for mentoring me on this project and seeing these cases with me. These are the mandatory Josh slides. We have no disclosures. Okay, so the title of this is Mysteries Behind the Droopy Eyelid, a review of 2 cases with a chief complaint of ptosis. So essentially, I had 2 cases with identical chief complaints that came in within the same week at HOMA with very different underlying etiologies. So we're going to review the workups and review some literature relevant to the respective underlying etiologies. So the first patient, hold on a second, I can't see that. Okay, there we go. So the first patient is a 43-year-old female. Her chief complaint was droopy right eyelid. She first noticed it when looking in the mirror 1 to 2 weeks ago. No progression from onset. She said she has some double vision when looking upward, and she doesn't know if it's always present. She has headaches, but they're long-standing and not really associated. She denied changes in vision, eye pain, diurnal variation, jaw claudication, temporal tenderness, generalized weakness, weight loss, trauma, or neck pain. No real past ocular history other than needing glasses. She has hypothyroidism and vasculopathic risk factors, hypertension, hyperlipidemia, A1C of 13, obese. She had no surgical history, family history was significant for breast cancer and those other conditions she has. Medications are relevant to those conditions that she has. And she smokes a pack a day of cigarettes and not sexually active. What's going on here? Okay, so her vision was 20/30 -1 in the affected eye, which is a little worse, and her pupils were within normal limits. Her pressures were good on motility exam. She was primary in Hirschberg. She had a slight chin elevation at rest. She had about a -2 on elevation of the right eye, and diplopia on upgaze, which was alleviated with closure of one eye. Her movements were smooth, no eye pain on eye movements. External exam was normal other than the ptosis. Her color plates were full. Her red dot was slightly asymmetric. She couldn't tell, maybe it was a little paler, maybe a little more orange. But other than that, so the cranial nerve too, possibly, possible involvement, the vision was a little down in that eye comparatively, and had no improvement on pinhole, and she had this red asymmetry. But cranial nerves 4 through 12 were intact, including corneal sensation. Resistance to retropulsion was symmetric and normal. Her tele was
I've
normal.
had better days.
I'm sorry? Oh, okay. No lid lag, no retraction, no injection over the rectus muscles, and there was no eyelid fatigue, and she had a negative ice pack test. So on her slit lamp exam was significant for ptosis in the right eye, and she had cataracts, but otherwise her exam was normal. So she had a superior division cranial nerve 3 palsy. Can anyone, any of the first years give me a differential diagnosis for this?
I guess I would think microvascular.
Okay, that's good. Can anyone want to throw one more out there?
I mean, I think less likely, but like an aneurysm maybe.
Yeah. Okay. So that's really good. So essentially, she's got a pupil-sparing third nerve palsy, superior division, and I give a pretty extensive, differential diagnosis here, and we're gonna run through these as we can go through the workup. So essentially, what we ordered an MRI and MRA of the heads in orbit with and without contrast, gadolinium, fat suppression, and flare, just because we were concerned based on the fact she was a white female with in her 40s with neurologic symptoms, and especially the cranial nerve 2 involvement. So they came back with the normal limits. There were no abnormalities. We ordered a CBC, CMP, ESR, and CRP, and everything was normal except an elevated blood glucose. So in reviewing the differential, I just wanted to go through these. So going back with all that information, myasthenia, the pupils are always spared, and her pupils weren't involved. But she didn't have fatigue, negative ice pack test, no diurnal variation, so less likely. Thyroid eye disease, she did have hypothyroidism. However, she had no exam findings that were supportive of that. We went over those, and imaging was with normal limits. Idiopathic orbital inflammatory syndrome, similar, no proptosis. Imaging was with the normal limits. CPEO, that will present more bilaterally and kind of a slow progressive onset, not sudden and unilateral. But the pupils always spared in that as well. MS, which we're always keeping our eye out for, is she had some neurological symptoms, and and the age was right, but she didn't have the optic neuritis symptoms. Her pupils were fine, and most importantly, the imaging wasn't supportive of that. Compression of mass. She said that she had a family history of breast cancer, although it wasn't early onset. And she didn't have any ophthalmos or resistance to retropulsion, and the imaging was normal. Skew deviation. The number one cause of skew deviation is vasculopathic, and it was asymmetric. However, we were able to explain this with not only just one cranial nerve, but also it was we were able to explain this with only one cranial nerve, and the imaging was in the normal limits. So we ended up settling on a microvascular ischemia secondary to diabetes, and her vasculopathic risk factors were pretty high. And the ones below, she didn't have any symptoms or risk factors for sarcoid, TB, syphilis, denied trauma. The imaging was within the normal limit for stroke. And for GCA in a 40-year-old white female with none of the risk factors, normal labs was a pretty good rule out. So essentially, we'll go over the epidemiology of this. So there's 4 in 100,000 cases of this in the population. Ischemic is the most prevalent cause of all cranial nerve 3 palsies and diabetes. The treatment and management, her GCA work was negative. We ordered the MRA, brains in orbit. They were negative. Some people also will order a neck if they're concerned. There's a Horner syndrome component. We said patching PRN. If someone's under 8 years old, you've got to worry about inducing like an amblyopia, but that's not the case in this patient. Tight blood pressure and blood glucose control. We referred her back to her PCP. Although she has one, she's obviously could be controlled better than an A1C of 13. We didn't consider Botox, but I just wanted to bring that up because the most common muscle involved in a diabetic is actually the medial rectus, and with the lateral nerve palsies in the acute phase, you can actually do an injection of Botox. But when the vertical muscles are involved, you really don't want to. There's a lot of complications to that, so that wasn't really in our considerations. And we were going to follow her up, and we're going to follow up in 1 month, and in 6 to 12 months, this should resolve, if not sooner, maybe even 3 months. And if a patient has longstanding diplopia from this kind of condition, you can offer strabismus surgery. That's later on, and if they're symptomatic. And also, if the ptosis doesn't resolve, you can do a Mueller's muscle resection, LVA, or frontalis sling as well. So, in all these kind of cases, I tried to pull out questions that I personally had and what I looked up, and then we put into the presentation. So my question was, in a patient presenting with a third nerve palsy or uncontrolled diabetes, what are the most common etiologies? And I was thinking, just like our bright first years, aneurysm, microvascular, and as far as imaging choices, what's appropriate to order under these circumstances. So in this study, Dr. Keene is a neurologist, and he looked at 1,400 patients consecutively that he saw with a third nerve palsy, and he found that diabetes was attributed to 11% of his cases in this review, and the only things more common were trauma, 26%, and tumor, 12%. And so of the 234 patients that he saw with the third nerve palsy that were associated with diabetes, 2/3 were microvascular, so that's and about 50-50 were pupil sparing or pupil involving. Whereas a third of aneurysms, 98% involve the pupil. So if the pupil is involved, it can really be either. But if we're in an aneurysm, the pupil is almost always involved. So then my next question was imaging. So Wills and Dr. Google say the move is to order a CT, CTA, and if it's contraindicated or not available, then you should order the MRI. But in a study by Klein et al. Who investigated this, they actually found that MRIs are greatly favored as the initial test, and neurologists essentially 100% of the time will order an MRI first, which I found was interesting. It's important to know, though, if you're suspecting a subarachnoid hemorrhage or trauma, we can't forget that we have to order a CT non-contrast. If the pupil's involved, a CTA is the test of choice, especially if the patient's over 10 years old. And so, if we've got a pupil sparing third nerve palsy, based on all I read, what seems to be the treatment algorithm? And it's kind of based on history of vasculopathic risk factors. So if there's no history of vasculopathic risk factors, you really should order the test and order an MRI. If there is no history of, but if there is a history, you can wait. And in our case, we were kind of concerned about MS being a possibility, so that's why we ended up going forward with ordering it. But if you're not really concerned about that, the move is to wait. And in one study by Blake in 1995, they actually just did an MRI on 43 cases consecutively with third nerve palsies, and they actually were able to find the idea of the cause in 25 of 43 cases. So it is a useful test regardless, but in terms of saving money and being cost effective, you should hesitate if you are pretty sure it's a microvascular ischemia. So we're on to our next case. This is a 64-year-old female, also coming complaining of a droopy right eyelid. She was referred by her oncologist for new onset ptosis in her right eye, but the patient states that the eyelid has actually been like that for 6 months. She's got stage 4 breast cancer and generalized weakness and bone pain and weight loss. She's had slow progressive worsening vision over the years and denies diplopia, eye pain, flashes, floaters, eyelid diurnal variation, fatigue, pain in eye movements, neck pain, trauma, contact lens use, or eyelid surgery or eye surgery. Ocular history is only significant for refractive error and dry eye. She has hypothyroidism, hypertension, and stage 4 breast cancer. The past surgical history, none. Family history, she has family history of breast cancer and also vasculopathic risk factors. Her medications are all related to her cancer, and other than B12 and aspirin, and allergies and social history not really significant. So as far as her exam goes, her vision's is 20/70. Pinhole's a little better. Her vision's been slowly progressing down that. I reviewed Dr. Tipton's notes, and who's been following her, and she's had cataracts for a long time. I'm not really interested. Her eye pressures are good, 10 and 10. Pupils were not involved. Visual field, confrontation of visual fields were full. And once again, her right eye, her head was actually a little off axis. It was slight right head turn, and she had a little abduction deficit in the right eye. She had smooth movements, no pain in eye movements, and she did have a little diplopia on extreme right gaze, and which resolved with eyelid closure, with one eyelid closure of either eye. So, and her left eye was normal. Her color plates were full, red cell was symmetric this time. In a neuro exam, cranial nerve 2 we felt was intact, and 4, 5, and 7 through 12 were intact, including corneal sensation. So her external exam, she had periorbital fat atrophy, the right side greater than the left side. She was cachectic appearing and had temporal wasting. She had elevated lid creases on both sides, and she had 2 to 3 plus brow ptosis in both eyes. Although notably she had anophthalmos and hypoglobus in the right eye. She had equal resistance to retropulsion. On her TEL was significant for a 4 millimeter difference in the right eye. Her MRD1 were significant in both eyes, but 1 in the right eye and 3 in the left eye respectively. Her levator functions were full and normal. And when lifting the right eye manually, the left eye dropped very slightly. There was no eyelid fatigue on sustained upgaze. So on her slit lamp exam was relatively normal, other than the ptosis, which I mentioned in the right eye, and a little in the left eye, and also she had pretty nice cataracts, and her dilated exam was normal, and her nerve was pink and sharp. So she ended up having a mixed mechanism ptosis. She had brow ptosis. The brows were well below the superior orbital rim, and we were able to isolate the frontalis muscle and by pinning it down. And even with frontalis, she wasn't able to compensate. She had acquired aponeurotic ptosis, commonly seen in elderly patients. She had an elevated lid crease, but the levator function was good, which is classic for aponeurotic ptosis. And she had a little asymmetric masking. And for the first years, Herring's law states that when you have you're going to have equal input to both to muscles on both sides of the eyes. And so by lifting the right lid manually, the left eye is going to have less input, and the left eye will drop. That's seen in a lot of ptosis, and it can a lot of causes of ptosis, and including myasthenia. But there's many types of ptosis that will happen, and it was just very slight in her. So now we were also wondering, we know it's mixed mechanism, but is there a neurogenic or mechanical component to this? So when reviewing different causes of a possible sixth nerve palsy, the most common causes are vasculopathic trauma and idiopathic in adults. This is, but the more uncommon causes can be you have masses, sarcoid vasculitis, strokes. So her lab, she had recent labs, and her blood pressure that day was within normal limits. A1C was normal, blood glucose was normal. We didn't order an ESR or CRP, but we deferred that at this time. And so the question is, should you image a sixth nerve palsy? Imagining for a second that ptosis might not be related. And so if it accompanies any other neuro-ophthalmic signs, then yes. And so we know that the ptosis, so with the ptosis, yes, that would be the answer, yes. But just the history of cancer alone, if we imagine the ptosis was all attributed to like the aponeurotic and brow ptosis component. And if a patient has bilateral ptosis in isolated or papilledema, you need to order also. That wasn't in her case, but either of those two would be indications alone to order imaging. So I'm going to spare the first years. We have a T1 MRI here. The cut on the left-hand side is axial, on the right-hand side is coronal. It was a little difficult. It's a little difficult for me to appreciate personally, but if you look on the lateral rectus muscle, it's a little enhanced. And the radiologist actually read this as possible metastases to the orbit, as well as other inflammatory possibilities. If we look at this image right here, we can see that you can really appreciate the hypoglobus in the right eye. So overall, the impression was there was a little microvascular change in the brain, which could possibly, if you were really pulling at strings, could cause a sixth nerve palsy. But with the presence of the tumors being found where the hyperintensity is consistent with the tumor being found in the lateral rectus and in the right orbit in general, it required, that was the primary consideration. So essentially, just in review, we've got a mixed mechanism ptosis here. Aponeurotic brow is their mechanical component. And could we, and if we weren't concerned about cancer, you could follow it with a taped and untaped visual field and determine, and proceed with surgery or with oculoplastics if the circumstances were different. But now we know we've got this abduction restriction and it's mechanical. Dr. Al-Hariri felt confident enough just based on the clinical picture to actually contact radiation oncology, and we asked if they would feel comfortable treating her with radiation prior to a biopsy. However, they declined because she had extensive metastases to bone, but not soft tissue elsewhere. So they required a biopsy. And actually, I believe one of the home residents might have actually taken her to the OR today. So maybe at the end of this presentation, we could find out what they saw, at least grossly. And so she also had an ophthalmologist at hypoglobus, and that's really the key here. So just quickly, I want to talk about orbital malignant orbital metastases from breast cancer. So it's the most common malignant condition in a female who presents with an ophthalmos. Reifer did a study in 1985, and essentially they found 25. He saw 25 patients over a number of years with an ophthalmos attributed to METs, and 3/4 of them were breast cancer. And the question, why, most of the time when you have a metastases to the orbit, you think of proptosis or a tumor pushing the eye out. But actually, with breast cancer, especially lobular carcinoma, the fibroblasts actually become activated in the surrounding tissue and contract and pull and tether the eye in, and that's why you have the anophthalmos effect. And so it's a classic triad that you should really be aware of: anophthalmos, ptosis, and restricted eye movements. It's seen in 32% of patients with breast cancer METs to the orbit, according to the Shields, and they're the experts on these sort of conditions. And these conditions, these metastases happen actually pretty early in the disease course, prior to our contemporary or current screening methods with mammograms. Ophthalmologists were actually diagnosing the breast cancer due to these METs to the orbit over 50% of the time before the primary was actually found. So my question for this case was, what's the management for when you find a breast cancer metastases to the orbit when a patient already has a diagnosis of breast cancer, and what's the prognosis? So this was a study done from New Zealand, and they had 11 patients with metastatic breast cancer to the orbit and the choroid, and they're all this has been a long-standing treatment is to treat with palliative radiotherapy. If it's involved in the choroid only, in 5 of the 6 cases, they found improvement, visual improvement in fundoscopic, and there was orbital. And if it was orbital metastases, they regressed 60% of the time, and they had improved proptosis and pain relief. It's interesting they said improved proptosis as a marker, because most of these cases present with anophthalmos, but that's one of the ways they measured it in the paper. But the biggest takeaway here for me was that the median survival time at diagnosis of orbital metastases after biopsy was 5 months, with the survival ranging from 6 weeks to 6 months. So this is unfortunate. It's very sad for our patient that this is a very serious diagnosis. So I just showed just a quick takeaways, and we're gonna do questions. These were 2 different cases, and they had they presented similarly with right-sided eye droopiness. They came in and they ended up having an underlying extraocular movement restriction. And so it's always important to take a really good history and keep the chief complaint in mind, but also look for other findings. One of the best parts of ophthalmology is that we can see so much in the eye, and our exams are so good. Diabetics with pupil sparing third nerve palsy. Imaging choices based on history, and breast cancer METs to the orbit. Remember, anophthalmos, the treatment's palliative radiation, and the prognosis is really bad. Thanks everyone for listening, and if I have maybe some time for questions, if anyone has any.
Hey, Zach, it's Alejandro Leon with Ophtho here at Children's. Hey, regarding your third nerve palsy that's pupil sparing, the main thing that you want to make sure, if it's a complete third nerve palsy that's pupil sparing, and in those situations you could say, okay, it's microvascular, I'm okay. It's a partial third nerve palsy that's pupil sparing. You cannot rule out that it will become pupil involving. You only have a few of the fibers being involved, and it can progress to be pupil involving. So I would agree on your patient to have the imaging. Maybe I read it wrong or heard it wrong, but even if they have and again, I'm not a neuro-ophthalmologist, but I guess I would place caution in just saying it's microvascular if you have an incomplete third nerve palsy.
Okay, thank you.
And Zach, for the first years, can you tell us why compressive lesions tend to be more pupillary involving?
So the nerves that run, the nerves that control the pupil are more internal or more medial in the nerve fiber. So when you've got a compression, you're more, that's how you're more likely to reach those nerves. And that has to do with the blood supply throughout the nerve.
Great, thanks.
Also, Zach, this is Nicole. Her case got canceled today because she was actually really sick. So the biopsy did not occur.
Well, in the future, if you guys end up doing it, you'll have maybe next week. Is it rescheduled at all, or?
Not at the moment.
Okay. Okay, well, we're done with questions. Thank you very much, everyone, for your time, and hope everyone has a good rest of their night.
Nice